Here is a case of pelvic ectopic kidney with PUJ obstruction, operated open pyeloplasty, now came with re-PUJ obstruction, ultimately ended up in reverse Boari flap. That's what we wanted to share. 27 years old male patient, right loin pain, open pyeloplasty at the 9 months of age, Gibson incision scar, ectopic right kidney located in the lower abdomen. This is the PUJ obstruction and VUJ obstruction. Both obstructions were there. Then even stent has not gone, ureteric catheter has not gone, function has decreased. So when you compare, you can see the graph. These are the ports position. Now when I went inside, directly kidney is felt. There is no problem. That is a pelvis, bladder, and you can in fact see the ureter also. Just above the ureter, directly I opened the pelvis because there is nothing will be there. Directly I opened the pelvis. The moment I opened the pelvis, the urine is drained out and I could see the ureter by the side. So most dependent part will be, see, you can see the inferior calyx. This is a cup kidney, cup. There won't be lower upper pole. This is the end of the pelvis. That's all. We cannot go beyond that. That should go to the pelvis. Now when you saw the ureter, see, I dissected the ureter a little bit. A pulsating vessel is seen. Carefully, ureter is separated. Anyway, this ureter is of no use because in the lower end, it is completely obstructed. This is the primary opening in the pelvis of the ectopic kidney, where you can see the lower pole calyx. Now, this is a reverse flap. Now, bladder is not mobilized. Normally, Boari flap is done anterior. Here, posterior wall Boari I have done. Directly, I have opened the bladder. In recent past, we are doing Boari flap, we directly open. So, it is just nearby. Even the bladder can be put into the pelvis, but we thought we will do Boari. Now, at the base, we use the cautery, but in the tip, we cut with cutting cautery. See, there is no coagulation effect. This is the flap. Small flap is enough. This flap, we have to like that, it will come after dropping the bladder. Now, we have taken tumble square knot, you can observe here, to the umbilical region. This is a tumble square knot, is my favorite knot. This is basically a square knot. Then you pull this is, see, the tumbling has happened. Now you pull the main thread, that is this, and then thread it. Everybody does this. Some people does with name, some people does see. It cannot go back. No loosening. This is testing to the anterior abdominal wall. Now I have taken the reverse bites, continuously sutured the bladder and also made the Boari flap. So here the blood supply, people may argue that it comes from the posterolateral region. Anterior vesical artery also will be there. One side posterolateral, on the right side blood supply may cut off, but the anterior and opposite side blood supply will be there. Very pink, very bleeding edges were there. Absolutely no problem. After my posterior suturing, then I have cut the stay stitch. Now I dropped the bladder. Why anterior bladder flap is not done? Because anterior bladder flap will not sit into the cup of the kidney, because the cup is facing to the umbilicus. So it should come like this only. You cannot do opposite direction. Now stay stitches are taken to fix the mucosa. So if you take anterior bladder flap, the mucosa will be facing umbilicus, and even ectopic kidney mucosa also is facing umbilicus. How can you bring together both? That's why we have done this. So 2-3 stay bites, if you take, the mucosa does not get separated. In fact, we don't separate the muscle mucosa like that. The shawl should be intact. Now see here, I am taking the continuation of that. Now this is the, almost it looks like ureter, small ureter, this Boari flap. The V-lock is very useful here. You can appreciate here. So you can appreciate one instrument 9 mm is going into the, see, every time mucosa should be taken, every time this should be taken, and then you knot it. That's the end. Entire thing will come now as C. Now like this it will fall. Now the bladder can be mobilized some more if you want, or It's enough because some elasticity will be there. This is the first angle bite, outside in, and then inside out. And on the other, this is a ureter. I have removed the ureter because it does not serve any purpose. And one more thing, a tubular structure lined with epithelium should not be there in the body. We have taken it out. Now one more bite we have taken, outside in, on the other side of the angle, so two bites on either side of the angle, both are pulled down and tightened. On both the sides we repair. This is a standard repair how you do the pyeloplasty in ectopic kidney, nothing new. But only thing is here flap we are suturing. Exactly it fit into the opening which I have done. A little stretched, but that acceptable for the bladder. And that for that reason I have the edges I have trimmed because they were little cauterized, so that see now stretch and suture it perfectly, it will fill. Now we are putting the stent after some time, and then see that this is the stent easily goes, even the suction sheath also goes. It's the most dependent drainage. First pyeloplasty they have done wrong. Why the lower ureter got stenotic, we don't know. So ultimately on either side if you do, chances of nice fall will be good. So we have come, see now it is sitting like that, almost like a ureter it is looking. There was a pulsating vessel every time we were careful. See, these bites with robo, they are advantage because you can take in opposite direction with angulation. Laparoscopy also we can take, but little difficult. See, we are coming to the end. So we made a closure here because I wanted to take the interrupted bites here, interrupted bites like this. See, I wanted to correctly into the opening which I have made because it was coming nicely instead of closing. See, now carefully I have taken. These are magnified views, so no dog ear present. This is a normal vicryl because V-lock is not required. Or see, now two bites are taken. Before closing, anytime I take like this, one bite on the other side, one bite on the other side, so that they sit properly. This is ultimately some more bladder because there will be space on either side of the Boari flap. I want to fill that with fat so that internal herniation of the bowel will not happen. See, this is the new ureter type of filling into the no leak, and these two sides it will fill into gaps over the sigmoid column. This is the play, and the moment the patient stands, entire urine comes out. To conclude, these are the only three stitches. Very rarely ectopic kidney, pyeloplasty, both pelvic ureteric junction and uretrovesical junction are damaged. At the same time, the Boari flap, if you want to, pyelevesicostomy is a described procedure, but we wanted to make it completely gravity dependent as it's a failed case. I made a reverse Boari flap. Thank you very much.